Good evening, everyone. It's gone just 6 o'clock. Welcome to you all, and thank you very much for joining us for the first of a series of webinars brought to you by the South West London lead provider for trauma and orthopaedics and MSK. And the purpose of the lead provider model is to provide a platform to support any urgent transformation that's needed in the recovery of services, but also to enable the sector to adapt and to improve with the aim of achieving the best possible clinical practice, raising the standards and quality of care for our patients by standardizing pathways and minimizing unwarranted variations. So we felt that it was really pertinent to support all the work that's being done across primary, community, and secondary care by implementing a training and development program that's delivered by experts across South West London. And the aim of the training modules is very much about streamlining the referral process so that it's easy and user-friendly for clinicians, but also for patients, eliminating delays, any duplication, sort of ensuring that the patient gets to the right place at the right time. So we're going to be having regular live webinars on different topics and subspecialties, and we are going to be recording these webinars, so you don't need to record them yourselves, and then we will have them available to view on particular training platforms that we can give you the details of. So what I'd like to say is, if you don't mind, to post your questions in the chat function, but you would need to select to all panelists and attendees in your drop-down just to make sure that we're getting that. And then we will endeavour to answer all of those questions after the presentation. We will send you a feedback survey in the coming days, and after we've received this back, you will have a certificate of attendance as well as a reflection sheet that will go towards your CPD. So without further delay, let me introduce our speaker for this evening, which is Mr. Suleiman Al-Azawi, who is a consultant orthopaedic and trauma surgeon based at St. George's University Hospital and the South West London Elective Orthopaedic Centre in Epsom. He specialises in hip and knee replacements and treating painful joint replacements. And today's topic relates to hip osteoarthritis and the referral pathway, so an ideal patient journey from a hip osteoarthritis point of view. And we've got 46 participants already, so I think, Mr. Al-Azawi, over to you.
Thanks very much, Claudine. Thanks for the invitation. I'm going to share my screen. I think you need to enable me to share the screen. Host disable attendee sharing screen. Okay. Sorry, I'm just having a problem with sharing my screen here. Okay, here we are. Excellent, thank you very much. My name is Suleiman Al-Azawi. I'm a consultant orthopedic surgeon. As Bodine said, I'm specialized in hip and knee joint replacement. I work at the complex arthroplasty unit at St. George's Hospital. We deal with the primary joint replacement as well as patients with high risk like lymphedema or hemophilia, renal dialysis patient. In addition to that, we deal with redo surgery, revision surgery for failed joint replacement for infection or other reasons. But most of the workload we do for straightforward primary joint replacement being done at the South West London Elective Orthopaedic Centre in Epsom. The centre is shared between 5 different hospitals: St. George's Hospital, Croydon University Hospital, Epsom and St. Helier, and Kingston Hospital. And the centre produces nearly 3,500 to 4,000 joints per year. This workload shared between more than 30 consultants across 5 different hospitals to produce this amount of work. And the talk today, we're going to learn more about hip osteoarthritis. We will discuss about how does the patient present to us. What about the non-operative treatment we can offer to the patient prior to going for surgical route, red flags in that topic, and when and where to refer the patient to have their total hip replacement. And then we discuss some of the questions that we all have and we wondered about the hip replacement surgery, and we talk a little bit about the post-operative management and then the referral proforma. So the patient with hip arthritis, they usually present with growing pain. That's the classic hip arthritis, growing pain radiate down to the knee. Pain happen over years or months, increased recently, and that's the way how the patient presents. We have to be very wary of patient complaining of buttock pain, especially the upper part of the buttock, because this is usually sacroiliac joint arthritis or a lower spine arthritis or lower spine pathology rather than pure hip arthritis. And also the lateral side hip pain is usually trochanteric bursitis, gluteal muscle tendinopathy rather than hip arthritis. So if the patient finger points the pain to the lateral side and is clearly tendon on examination, this is more trochanteric bursitis rather than purely hip arthritis, although both could exist on the same patient, and patient with trochanteric bursitis may have also hip arthritis. But the same would apply with the buttock pain. If patient coming with upper buttock pain, this is not the classic hip arthritis pain. We have to be aware of that. We assess the severity of their symptoms. I find it very useful to ask them how many minutes can you walk before your left hip stopping you from walking, not because of the shortness of breath or because you're feeling tired or because of lower back pain. And if the patient say 15 minutes, it's very clear to everyone walking distance 15 minutes versus someone can walk 3 hours time. I find it much more reproducible than asking them walk half a mile or 1 mile, because maybe my half a mile estimation different to the patient, different to you, half a mile, and therefore time will be really best way to ask the patient about it. And then we ask them about night symptoms. Do they get pain at night? Does the hip pain wake them up during the night? How often? Once or twice a week or more than that? Other symptoms they complain of is limp. Very common. Patient have antalgic gait, abnormal gait, and could be noticed by the patient or by their family or friends. They have a stiffness in their hip, and they certain daily activities they cannot do it anymore. Simple questions for the hip arthritis. You ask them, how do you find it putting socks on, or tying your shoelaces, or cutting toenails? And you find these particular activities where the hip have to be in the extreme range of motion, they're unable to do it because the hip is getting stiff and they have very restricted range of motion, and these hip movements are going to be very painful for them to perform. So what do we have in the differential diagnosis with that? It could be lower back pain, the one most common one, and the one which sometimes really hard to say whether this is a hip pain or it is a lower spinal pathology. This is always, we have to think whenever someone presents hip pain, is it hip or back? Trochanteric bursitis, as I mentioned earlier, the lateral side hip pain, the tendon on examination, that goes more with trochanteric bursitis. And the upper buttock pain, the lower back, upper buttock pain or lower back pain, which more the sacroiliac joint arthritis. And because the classic presentation is groin pain for hip arthritis, you have to be just wary that this patient doesn't have underlying hernia causing the symptoms. In a younger patient, we think more likely they may have a labral tear or femoral acetabular impingement or a vascular necrosis, less likely to have arthritis in their hip joint. The red flags on this subject, we need to be wary of any trauma. Even the patient walk to us to the clinic or walk to the surgery with history of trauma, because they can have fractured neck of femur, impacted valgus, what we call impacted valgus fracture neck of femur, and they're still able to walk with a lot of pain, but they can have still fracture neck of femur. So trauma, always we have to ask, do you have any fall, and sometimes patients tell you, I had a fall 3 weeks ago and I've been struggling since then. And when you x-ray them, actually they do have a fracture. The sudden onset pain, that doesn't correlate with the hip arthritis. Inability to weigh bear, make you always think this doesn't look arthritis. Arthritis, you're still able to walk with a lot of pain, but you're still able to walk. Any lump, any swelling, any enlarged lymph node, this doesn't go with hip arthritis. This is something else. We need further investigation for that. Weight loss, fever, night sweat, unusual pattern of night pain. And we talked about the assessing severity by asking the patient, do you experience pain at night? And yes, they say yes or not, and we say yes, that's severe pain. But the usual hip arthritis pain is the pain it's happening. If you ask the patient, he tell you, I put a pillow between the knees, for example, or when every time I turn to the side in the bed, I feel the pain, I wake up. It's pain associated with movement. The unusual pattern of pain you worry of is the pain even when they are at rest. Even when they're not moving the hip joint, they're experiencing severe pain out of proportion to what you expect to have with the hip arthritis pain. Then history of malignancy, especially active malignancy, always make you think, is this metastasis to the hip joint? In terms of the clinical assessment, there are plenty of ways how to assess them patient clinically, but the simple way you can see them when the patients start walking, they have a limp, they have antalgic gait. If you do Trendelberg test, they're unable to balance, they have a painful hip joint. And when you examine them in the bed, they have a loss of the internal rotation. Most of the hip movement will be stiff, will be limited, will be restricted, but the one very specific and the first they're going to lose, they don't have internal rotation. So if you flex the hip to 90 degrees, try to internally rotate the hip, there's no internal rotation in the patient with hip arthritis. Always we check the sciatic nerve function because it could be spinal pathology what we're looking at. How do we investigate them? If you look to NICE guidelines, they say if you have someone above 45 and you think they have hip arthritis, you don't have always to x-ray them or do investigation. And maybe that's the case. If someone coming with very clear history, mild symptoms, and he's 75, you can treat him as hip arthritis for a short period of time and check the response. But in practice, most of the time, we end up doing an investigation to confirm our clinical suspicion at some stage. And the only one test we need for hip arthritis is the plain X-ray. It's simple, it's reproducible, and gives us all the answer we need. We don't need MRI or ultrasound, we don't need anything. That plain X-ray shows hip arthritis on the right side. But the catch is normal hip X-ray doesn't always mean there's no arthritis. We have to manage the patient based on the symptoms. If they have a normal X-ray and ongoing pain, then it's reasonable to consider a referral at this stage if the symptoms haven't settled with normal X-ray, because it could be either they have arthritic changes that are not visible on the X-ray, they may need MRI scan, or maybe the hip is not the source of the pain, something else like spine or sacroiliac joint, so we need further assessment and maybe further investigation. So normal X-ray doesn't, we're going to tell the patient that's it, nothing going to happen, we're going to continue. You have to assess them based on the response of their symptoms. Young patient, they can still get arthritis. It's not the primary or idiopathic osteoarthritis we experience as we get older, but the young patient can have it. Like in this patient, he's 28, he had bilateral avascular necrosis, needed bilateral hip replacement. This is another patient in the 20s, have deep socket or acetabuloprotrusion, develop hip pain and required a hip replacement. This is a teenager patient who needed a hip replacement later on. He had septic arthritis when he was 3 or 4 years old and subsequently developed arthritic changes in the hip joint, and I did hip operation when he was 18. So that's another example. Or simply they have previous trauma, and as a sequence of the trauma they develop arthritis in the hip joint. So the young patient can still have arthritis, but they are usually secondary to other causes. Now we're going to talk what we can offer this patient before we go to the surgical option. We go first with the education. It's very important to explain to the patient the nature of the disease. You will have good days and bad days. Your symptoms will vary between times and days, usually worse in the winter, better in the summertime. And it's not a cancer or heart surgery. It doesn't mean you have to have surgery for it if your symptoms mild or moderate. You can manage them with painkillers, with other modalities. We're going to talk about it now. And there's a lot of misconceptions about hip replacement. We will talk about it as we're coming through the coming slides. The other things maybe modify their level of activities. If someone does jogging or running or touch rugby, maybe you advise them to avoid the impact activities, go more to non-impact activities. The second things we can offer the patient is analgesia. And we know non-steroidal anti-inflammatory drugs are the most effective medication for arthritic pain. And if we start prescribing opioids for patient, maybe we should think twice. Maybe this is a patient should be referred for consideration of joint replacement rather than having a regular prescription of opioids. Physiotherapy is another important element. They get muscle strengthening, general aerobic fitness, and that's what NICE recommends for all patients with arthritis. But again, we tailor this based on the patient need. If you have the 45-year-old builder who's really very strong, very active muscle, and he's telling you, I've been using ibuprofen and paracetamol over the counters over the last year, there's no need and there is no value to achieve, nothing we're going to achieve by referring this patient for more physiotherapy, because clearly on examination, he had really good power muscle in his legs. Delaying him by adding him 3 months or 6 months, it doesn't add any value. There's no goal to achieve by sending him physiotherapy, different from a lady who's 80 years old, have done 0 exercises, which you benefit from muscle strengthening, strengthen your abductors muscle and improve the range of motion, and then reassess your response to that. Weight loss, it is effective, but we have to be aware that weight loss is much more effective in knee arthritis than the hip arthritis. So the benefit for hip arthritis with weight loss is marginal. Nevertheless, we should encourage patients to try to lose weight because of that marginal benefit, plus reduce any perioperative complication, plus it's good for their general health. Walking aids, again, the same example, the 45-year-old builder, he will not going to use a walking stick, but maybe the 80-year-old will be very happy to use a walking stick if that means they're going to avoid surgery. At some stage, we have to think when we're going to stop non-operative and when we should not consider the non-operative treatment. Well, in the patient would have advanced arthritis on the X-ray with night symptoms, once reach that level of severe radiological images and severe symptoms that affect their night sleep, the role of non-operative treatment will be very limited. There's not much we can reverse at that stage, and probably they should be considered straight for referring for surgery. And maybe if we try non-operative treatment for other patients after 3 months or so, and there's no response, not even slight response, maybe clearly they are not responding well, and maybe the non-operative measurement is not working for them anymore. But this will be tailored based on each individual. Cortisone injection, we do use it occasionally. It does give you short-term pain relief. We use it most of the time for diagnostic reasons. So I use it if I wasn't sure patient have chronic back pain and now presented with hip pain, not very classic hip pain, and we're not sure this is the hip or it's the spine. So the best way is you inject them with local anesthesia and cortisone and the ultrasound guidance and the fluoroscopy guidance, and then you assess the response. And if they responded very well, even for 1 day or 2 days or 2 weeks, then we know that the hip is the source of the pain. So if you're going to replace the hip, they will have very good results. But if the patient come back to you and say, I have zero response, no pain relief for whatsoever, even for 1 day, then we know it's not the hip is the source of the pain, this is spinal pathology, and replacing the joint will be a wrong procedure. So this is done under fluoroscopy or ultrasound. So it's intervention done in hospital. Either the patient have to be referred to orthopedic clinic to have this intervention, or if the referral person able to refer them directly to have that intervention, then that can be done as well. Now so when to refer the patient for joint replacement, we always say when it affects their impact, and it has significant impact on their quality of life, affect their daily activities, their quality of life, their night sleep. And when they try non-operative management and they have not been successful to control or improve their symptoms. But again, as we said, we're going to tailor this based on patient need. The 45-year-old builder who very strong muscle, who been in analgesia, self-medicating himself, we will not have much value with physio or with analgesia or walking stick with him. And maybe if the X-ray shows advanced arthritis, he's a person should be referred directly to consider for consideration of surgery for him. Other checklists, we need to check with the patient, do they want to have surgery? Is not almost every clinic I do all day clinic, but usually I get one patient who do they have generally arthritis, who do they have bad symptoms, but when you start explaining them about joint replacement, they will say, no, I don't want operation. There's no way I'm going to have a joint replacement. So why you are here then? So it's very important, simple question. If the answer to your problem is a joint replacement, is that something you'd like to consider? And if the patient say, no, I don't want to have operation, there's no point to, it's a useless exercise to everyone and wasting everyone's time. So there's no point for this patient to be referred. If the patient anxious about it and want to ask questions, by all means, he can be referred and have that discussion with the surgeon who's going to operate on him. The other simple thing is checking on ongoing infection. Does the infection with recurrent urinary tract infection or ongoing fungal infection, dental abscess, skin ulcer, because all these are contraindication for operation. We're never going to operate on someone who had the ulcer on the same leg because the risk of infection in the hip joint will be high. The same with the ongoing infection. So maybe this patient is reasonable to try to manage this infection first, and once they cleared, then they're referred for consideration of surgery. And obviously, the patient have to be medically fit for surgery. And I then underline that because I've always find it's difficult for me as a surgeon or as a physiotherapist or as a primary care physician to decide, is he fit for surgery or not fit for surgery? It's not something we can do, but maybe some simple intervention we can do to all patients who do full blood count, because and do HbA1c, because if they are poorly controlled diabetes, they need to have better control for diabetes. And if they are anemic, then we are aware on the referral this patient has anemia, and we can fast track the patient to go to the anemia clinic and adjust that. But ultimately, the high-risk patient, they go to high-risk anesthetic clinic seen by anesthetists, which I find it very useful exercise. When I meet these patients, I will sometimes refer them to the clinic without listing the patient for surgery. The patient can have a consultation with one of the senior anesthetists regarding their risk, and then they can objectively tell them the risk of mortality, the risk of major complication, minor complication, and the chances of this patient discharged to the residence versus going to rehabilitation place. Then they come back with all these figures to the clinic, and then we have another discussion. A patient who had mortality rate 15 or 20%, may decide not to go for hip surgery, and that's very reasonable, versus someone I thought he's high risk, but when he go to the anesthetic risk, they found it actually what I thought is a high risk for them, that's not as significant as I thought. So it's very important to exercise that, and that's the way how we deal with our patients, whether this is at St. George's or at the EOC. We have high risk clinic for these type of patients. And sometimes maybe the answer for this patient to have the operation not at the elective patient. We have a special cohort of patients like those on kidney dialysis, hemophilia, sickle cell disease, lymphedema patient, where we need a support from other medical specialties. This patient, we perform all the operation at St. George's because we have big hematology center, dialysis unit, and big lymphedema team. So do this operation there, we can get support from other colleagues in the hospital. So the question then, when should I refer the patient? Well, it all depends where does the patient live, because all the 5 hospitals, the surgeon who operate, the surgeon from this hospital operate at EOC. In addition to that, we do have outpatient clinic at EOC as well. So you can, if the patient lives closer to Kingston, refer him to the surgeon to Kingston. The clinic could be based at Kingston, but the ultimate operation will be done at EOC. If the patient lives locally to Croydon, the same things will happen, and so on. So it doesn't have to necessarily refer to one particular place. They can refer where they're closest and more convenient for the patient to go. But ultimately, all these patients, they will be operated at EOC unless the operation requires special attention from other medical team. As I explained earlier, then they will have it in one of the base hospitals. Now, some of the misconception, patient telling you, I'm too young to have a joint replacement. I've been told you are too young, I shouldn't have it. Well, the youngest patient I ever operated on is 14 years old girl, and the oldest is 94. You have all range of patients. There is no too young to have a joint replacement. This is completely misconception. But what the patient need to be educated at is the younger you are, the more likely you may require redo surgery, revision surgery. So if you are 48-year-old and having no hip or knee replacement, most likely in your lifetime, you will require to have another surgery to change the hip joint or the knee joint you have. But when you are 78, most likely that's it. That's the only operation you're going to have in your life. And if everything goes well, no dislocation, no infection, no complication, that's the only operation you're going to have for the rest of your life. You don't need it to be done again. So there is no concept of being too young to have a joint replacement, provided the patient being consented and aware of the risk of having it too young, that you may be committed for another operation later on in life. And then you have a discussion, do I stay in pain for 20 years so I don't have 2 operations? Or do I have operation now, be pain-free, enjoy my life, and then 20 or 30 years time, if I need to have it done again, I will deal with it at that time. Implant survival. Many patients, they come to the clinic and say, I've been told it lasts only 10 years or lasts only 15 years. This is a very busy slide, but it's a slide from the National Joint Registry in England and Wales, and it shows you on the first left column all the implants, cemented, uncemented, cemented and uncemented, what we call hybrid. And the last column will show you the survival at 15 years, which shows all the implants on average, more than 90% of all variable implants last more than 15 years. So when we say the patient, it lasts 15 years, doesn't mean day one after 15 years, you need to have an emergency operation because your implant has expired and we need to change the implant for you now. It means if we have 100 patients operated on today, and we're going to do phone call all of them after 15 years, 90 patients, they still have the joint in place. If you call them again in 20 years, maybe 80% of them, they still have the implant. If you call them after 30 years, maybe 60% of them, they still have the implant in place, and so on. And that's the reason why you say the younger you are, the more likely you may need another operation. But doesn't mean the implant only lasts exactly this amount of years. So when is the right time to have the total hip replacement? There's no right time. It all depends on the level of the symptoms. Do they need non-operative management, and is worth to use it? And if yes, that's the way to go for it. But as we say, there are certain circumstances when they have severe arthritis in the hip joint and they have night symptoms. There's no much value we're going to gain now. The severe symptoms, the advanced arthritis, maybe the surgery, we should pass them to have a surgery, versus someone moderate symptoms, haven't tried walking stick or analgesia or physiotherapy, who will probably worth to spend a few months trying to optimize them and see whether we can control their symptoms. This is an example between the left side X-ray, both right hip arthritis for the same patient. I'm going to magnify to see. We know the nature of the disease is only going to get worse. So this patient went with severe arthritis. He's a builder. He's in late 40s. And after 9 months, we X-ray him when he was referred to me, and you can see significant progression in arthritis. So arguably, this type of patient, maybe going straight for surgical option is the right answer for them, because there's no much to optimize. They already have very strong muscle power. They've already been on analgesia. They're very active, and the level of symptoms very severe. When it's too late, it's too late when although we will always say you should try non-operative management before we try to refer the patient, but we don't want to see is a patient who having significant muscle wasting or persistent abnormal gait, and as a result, they develop lower spine pathology, lower back pain. They start to lose their job because it's too painful for them to work, affecting their mental health, or they are in significant amount of pain that they are on regular opioid prescription. So we don't want to see these scenarios. We like to, if you like, catch these patients earlier than they reach to this stage to be improved on their pain symptoms, improve on their quality of life. We're going to talk a little bit about the hip replacement. So what does it include and what does it mean? Satisfaction rate is about 90%. So I tell the patient, if we do 10 hip replacement today, 9 of them will be happy. 1 of them might not be happy or satisfied because of the risk associated with the hip replacement. We say to all patients, it lasts more for on average 15 years or more, but I explain to them clearly, doesn't mean day one after 15 years need to be changed. I mean, if we have 100 patients, operate on them today, after 15 years, 90 of them, they have the hip joint, 10 of them may require to be the operation to be redone again. On average, patients stay 1 or 2 days in hospital, 14 days until the wound completely healed, and they go back to work in 2 to 3 months time, depends on the type of the job they do. At EOC, we apply self-management for physiotherapy. So the in-house physiotherapist, they will educate the patient, give them exercise, supervise them, and let the patient go to do their exercises at home. The patient can initiate their own follow-up for physiotherapy if they felt they are not progressing as they should be. But those who were identified while they were inpatient that they require extra additional support from physiotherapists, extra input, then they will give a routine follow-up appointments. 3 main things can happen post-operative, either wound-related issues. So if it's happened within the first 10 days, it's good practice. We always encourage them to contact the elective orthopedic center, which they can advise them, signpost them the right direction, either to come back to the center or to be in contact with the operating surgeon so they can arrange to see them much earlier. Those with suspicion of DVT or PE, on the other hand, probably the best action for them to go to the emergency department because they need more urgent treatment and they need scan to be organized. Pain prescription, most of the time patient will be discharged with enough pain prescription, but if they feel they require more additional pain prescription, they can obtain that from the general practitioner. So Bodine, I'm going to hand over to you at this stage to talk about the Proforma pathway and the for the hip replacement.
Thank you very much.
Okay.
So a high-level slide, and it's very small writing, so not to worry too much about the detail of it, but this just shows the NHS England and getting it right first time pathways for low complexity, high volume procedures, sort of all to do with the restart of elective surgery and streamlining pathways pathways across Pan-London, actually, not just Southwest London. So it's just to say that we're focusing today on that first part of the pathway, and it is aligned with what is kind of getting filtered down nationally so that we're all doing the same thing essentially. And it may be a little bit different depending on where you work across Southwest London as to how the patient presents. So it might be that they present first to a GP, or they might present to a first contact practitioner, or the referral may come through to secondary care from a single point of access MSK integrated team. So how your referral, sort of your referral pathway may be slightly different, but what we like to think of us is as one team essentially, and we want that pathway to be as streamlined as possible. And we want the referral to include all of those GIRFT and ECI standards within that referral, which gives a lot of information to the consultants in their clinics. So if you don't mind to just move on to the next slide. This is just an example of everything in summary that Mr. Alazawi has spoken about today in terms of when is the right time to refer a patient, what should the criteria be for the referral, what conservative management has the patient had, how is it affecting their quality of life, what are the patient expectations. So has there been that discussion in terms of the patient would be happy to have a surgery? So has that shared decision-making taken place? Have they had all of the sort of conservative management options trialed, like analgesia, activity modification, physiotherapy? Have they had any injections? Have they been given that smoking cessation advice, weight loss advice? So all of those things, all just in one place in terms of having a really strong referral, having all of those standards. Something like an Oxford HIP score is useful, but it's definitely not absolutely necessary in terms of an initial referral. And some of the sort of the HIP consultants would look at particular questions if it is affecting the patient, like the reduced walking distance, the stiffness around the joint, and how it's affecting their quality of life, as well as it's really important to include if the patient has had their X-ray or their diagnostics and where and when that took place, so that those can be sourced before the consultant clinic. And then it eliminates the need to have to send the patient again if those images are visible to the consultant. So it's kind of just everything in summary, and all the sort of criteria that the consultant would look for, and it gives a full picture. So that's just a nice way of showing everything on one page essentially. Back to you, Mr. Alazawi.
Thank you very much. And I think we go to see if there's any questions from the participants. I will stop sharing now. And
so we have got a couple of questions.
Yeah.
So this question comes from Dan, and he asked if anterior shin pain could also correlate with symptoms of hip osteoarthritis.
Anterior shin pain is less likely to be with hip arthritis. Usually the hip pain goes down to the knee. Once it's got beyond the level of the knee, is less likely to be hip arthritis.
Thank you. And then the next question is from Ronnie. She said that the messages are really clear, but what is required in the referral in terms of anything to do with blood tests?
So the idea of having blood tests, you don't have to do blood tests, but if I see a patient now today and I identify this patient needs hip replacement and the referral person already done full blood count and shows hemoglobin 85, I know by default 85 hemoglobin is too low to have surgery. So I put on my request referral need to be seen in the pre-assessment anemia clinic, where they can give him intravenous iron infusion, build up their iron and build up their hemoglobin level prior to surgery, which make the patient less likely to require blood transfusion. And maybe if the hemoglobin is very low, let's say someone who's 84-year-old and come with hemoglobin 67, we may think maybe this patient actually have bowel cancer or have GI bleed, because this is very low hemoglobin. Before we go to big surgery or wasting time on the waiting list for 2 months' time, maybe we should be investigating the local low hemoglobin much earlier. So just like a broad really test for us is very useful to know. And the same with the diabetic person, because if the diabetes were poorly controlled, maybe this patient needs some attention from the diabetic team prior to going with the surgery. So it's not essential, it's optional, but will be very useful if we know that on the day of referral.
Oh, sorry, Ronnie, I think I might have misinterpreted her question. She said, how is the message being communicated primary care in terms of, I suppose, the messaging. So one of the things Ronnie is doing these webinars, which are aimed at primary care. So we're advertising it sort of within the GP newsletters and filtered via the Southwest London Primary Care Communications team. And then I think it's about also us just getting out there and engaging with the different practices across Southwest London, because, you know, it's really huge, and a lot of practices are working in slightly different ways. So I think it's important that we will be getting onto the ground and engaging with the practices themselves, as well as the sort of different implementation of first contact practitioners within primary care. And I think it's about engaging with those first contact practitioners as well and bringing them together into the one big team. And then, of course, also our MSK teams and our single point of accesses, because everyone's working together. So I think it's, we're starting with our webinars, but I think it's going to take a while to be able to reach everyone. And if anybody's got any suggestions of how they feel would be a really good way of disseminating information, please do get in touch with me. I can give you my email address. It's b.pearce, P-E-A-R-C-E @nhs.net, and I'll write it in the chat as well, because yeah, it's very important that we get that message out there. I don't know if anybody's got any other questions. If you would like to, you could also raise your hand and we could give you the opportunity to speak. Otherwise, what I will, oh, Phil's raised their hand, Iram, if you don't mind to. Almost there.
So Phil's question is, at what stage should we refer back if progress post-op seems slow or pain is not settling?
I think it's very good questions. The patient should have a follow-up with the operating surgeon, and in normal circumstances the patient will not be discharged if there is ongoing pain, and therefore I assume, and what I witness in most practice, the patient will be satisfied, happy, minimum symptoms by the time of discharge. So if the pain develop later on, then definitely need to be referred, because that's something new has happened to the joint. We need further assessment for them. Ongoing painful joint is difficult because you have to assess, first of all, is it getting better or getting worse? If the patients say, I'm still have pain, but when you ask them, how was it 2 months ago? And say, no, much worse 2 months ago. I'm getting better, but in a slow pattern, then that's very acceptable way of dealing with it. But if the pain is not getting better, and after 2-3 months, probably is good to be referred if the patient being discharged. But I would be surprised if surgeon will discharging patient after 6 weeks if they have any symptoms. So hip replacement, they respond very well after the surgery. In 3 months' time, most people back almost to normal daily activities, and we expect them to achieve that outcome. Of course, there will be the exception, the one who was always in wheelchair dependent, and you've done hip replacement for him now, you not expect him to recover as quick as someone very active. But most of these patients, by default, they will be still have a follow-up with a surgeon if they still have ongoing symptoms.
Harriet's asked, is it possible to share the presentation? So yes, absolutely. And we will also we've recorded the webinar. So I will get back to everyone with exactly where the webinar will be available to view again. The next question from Atine is an X-ray enough to rule out hip replacement issue for a patient with pain following a fall? What are the reliable symptoms and signs when a hip prosthesis is coming to the end of its time?
So to answer the first question, just to be clear, the patient does not have hip replacement. They have a fall and complaining of pain. Is that the correct question? Because with fall, if the patient presented to the emergency department and have a fall, and we do X-ray, and the X-ray looks normal, clinically is a painful joint, no persistent pain following a fall on the side of previous. I see what you mean.
Yeah, so
no, X-ray in its own not always enough, and sometimes CT scan will be the answer to that. So you can have undisplaced fracture, periprosthetic fracture, which is not visible on the X-ray images, and hence CT scan will be the test of choice for that. And that's have to be done fairly in urgent basis, because you will probably need to give them crutches, limit their weight bearing, and occasionally you might need to operate on them to fix the fractured bone. So probably these patients should be referred to the emergency department, because that will be the quickest way to get CT scan for them done on the same day. And do you prefer weight bearing X-ray or doesn't matter? I will suggest for hip doesn't make a huge difference. For knees, it doesn't make a huge difference, weight bearing versus non-weight bearing. So if the patient being referred to me with non-weight bearing images, they will have by default up-to-date X-ray on arrival to the clinic with weight bearing. But with the hip joint, doesn't have to be weight bearing. They can be absolutely fine non-weight bearing.
There's a question from Hardik. If a patient has 1 or 2 risk factors regarding AVN and X-ray is clear, would you recommend further scan?
Yes, MRI scan, because AVN at early stage, it will not show the AVN yet, but MRI scan will show the AVN at early stage. The same apply if you have patients on one side have AVN and you diagnose that by X-ray images or MRI scan. Most surgeons will do MRI scan or at least X-ray for the other side, because there's a high chance you might have bilateral AVN. So to summarize the answer, MRI is the investigation of choice in normal X-ray images.
Brilliant. And then another question from Phil. What is the current advice on resurfacing of hips?
So I think most surgeons have stopped doing resurfacing. Even the surgeons who were very motivated before and do large volume of resurfacing, they have stopped doing resurfaces. It's going to be down to consenting the patient and informed decision with the patient. Of course, there are advantages of using the resurfacing. There's no questions about that, but there are risks associated with it. And nowadays, with the traditional hip replacement, we know if everything goes well, most patients last 25 years with no issues or no problem easily. And that makes us think much more harder to go for hip resurfacing. But you will get some patients who done their internet search, who are very keen to have a hip resurfacing. And then you have to have that informed consent with them and that discussion with the individual patients.
And there's a question from Sergio. What is the timing of CSI when considering future replacement in terms of risk of infection?
What's the first part? CSI? What?
CSI. I'm sorry, I'm not familiar with CSI offhand. Sergio, do you just want to say what that stands for? Intra-articular injection.
So, yeah, of course, it's an injection. Okay, thank you for that. Most of the surgeons wait 3 to 6 months' time. If you wait 6 months' time, you will be safe to perform joint replacement. But if you operate straight away in the first 3 months, the risk increase, and that's the reason we don't like to do that. So we prefer, if patient we do cortisone injection, we like to wait 3 to 6 months' time before we go with the surgery. And sometimes will be useful not only for diagnostic purpose, what I explained. You get the patient who do have arthritis, who do have symptoms, but they are currently investigating for bowel cancer or lung cancer. So this patient actually giving them the cortisone injection until they complete their investigation, it will be very useful for them because they give them some pain relief. They don't need to depend so much on the analgesia until they complete their investigation for the cancer or other medical problems. And then when they come back, you pass the 3 to 6 months time, which will be safe for you to operate on them.
Brilliant. I think that's all the questions we have. So we will be getting in touch in the coming days with the feedback.
I think there's one more question.
Oh, is there one more? Oh, from Harriet.
Oh, that's not.
So I'm a community physio for one of your total knee replacement patients, and she speaks very highly of you, Dr. Alizal.
That's very nice to hear.
I was very switched on by her operation and post-care from beginning to end, so thank you. Oh, that's a lovely one.
That's very nice, yeah.
Coming to end on.
So just one more question, sorry.
Erim's got one.
It's come on the question. Would you still consider operations on individuals who are more older with multiple comorbidities? Could we still refer?
Yes, 100%. I mean, the high-risk patients for me and my colleague, Mr. Sammers, Mr. Mitchell, we tend to do them as St. George's if we felt there is need for them. Otherwise, we have HDU, high dependency unit at the EOC, and there we have high-risk anesthetics clinic there. We can, anyone from us, whether us or any of the other surgeon in the 5 hospital, we can operate for them at EOC as well. As I said, I find it very hard for me to tell the patient you are not fit for surgery because I'm not the best qualified person to advise patient on anesthetic risk. And I find the best, if I'm two minds, can they have the surgery or not? I refer them first to the high risk clinic. They have this consultation with them. They come back with objective figures as risk of mortality, 0.1%, risk of major complication. And then we can have more informed discussion with them and better discussion with them. And then the patient can decide whether they want to go for surgery or not, because at the end of the day, I tell all the patients, this is not a cancer surgery or heart surgery, it's your quality of life and your pain management. So that's the balance we need to have. So I think, yes, to answer that question. Timing for MMI following total hip replacement. That questions, I'm not quite sure why we do MMI for following hip replacement.
So the question that's in the
Yes,
question section is, could you please clarify timings for MRI following hip replacement? 6 weeks?
Oh, I mean, for MMI in general. So it's a really hard question, this one. And there is no, is it just, this is more a traditional practice that everyone thought 6 weeks is the time. For me, let's say an example, if I operate on total hip replacement and the patient for emergency need to have MRI scan, I will very happy for the patient, my patient, if emergency have it to have the MRI scan, they should have it straight away if there is a clinical need. One of the example, which is very rarely done, if the patient has on warfarin and develop a local hematoma and you develop foot drop and you want to see whether there's big hematoma, you want to exclude that, you need to have, or they develop epidural abscess in the spine after spinal anesthesia. Do you do MRI scan for the diagnosis or not because of the hip replacement? And always the benefit will outweigh the risk. So although most places and most radiologists are keen to wait for the 6 weeks, but really I don't think there is a very strong evidence one way or another. So I will say judge it by the clinical case itself.
Brilliant. Thank you everyone for joining us. We will send you a feedback form and we will also send you a certificate of attendance for your CPD, and I will also share with you where we will be uploading the webinar so they can be viewed again, and potentially being able to share the slides if Mr. Alazawi is happy for us to do so with our primary care colleagues. And we wish you a lovely evening. In 2 weeks' time, we will be having the soft tissue hip as well. So look out for that one. And thank you very much, Mr. Alazawi, for your brilliant and sharing your great knowledge with us.
Thank you very much. Thanks for all participants.
Have a lovely evening.
Thank you.
Thank you.